Welcome to this presentation of Innovations in the Applications of interRAI Assessments. My name is Keir Johnson from Doctors Manitoba, and I will be the moderator for this session. Today's presentation will be about the research behind the paper entitled Predictors of Improvement in Urinary Incontinence in the Postacute Setting, a Canadian cohort study. We will begin the presentation today with Dr. Bonaventure Egbujie. Dr. Egbujie is a PhD candidate at the School of Public Health Sciences of the University of Waterloo. His PhD research focuses on understanding the trajectory of physical function among older adults in institutional care settings and how this trajectory is determined by person-level factors. He is a qualified medical doctor, board certified as a general practitioner with the Medical Council of Nigeria and the Health Professional Council of South Africa. Prior to joining the University of Waterloo, he worked for over 10 years with various national and subnational units in Nigeria and South Africa to develop, implement, and monitor public health interventions, such as a donor-funded HIV/AIDS, TB, and malaria control program. He will be joined today by Dr. Melissa Northwood and Dr. Adrian Wagg. Dr. Northwood is an assistant professor in the School of Nursing at McMaster University. The focus of her research is health and social care system integration for older adults with clinical complexity and their caregivers. Melissa has practiced as an advanced practice nurse in acute care, complex care, and as a nurse continence advisor in home care. She is proudly certified in gerontological nursing. Prior to joining McMaster, she held the Canadian Institutes of Health research-funded Health System Impact postdoctoral fellowship with the SE Health Research Centre at the University of Waterloo. Dr. Wagg is a specialist in geriatric and general internal medicine with expertise in health services research. He is currently a professor in the Department of Medicine at the University of Alberta and associated professor with continence sciences at the University of Gothenburg in Sweden. Dr. Wagg is an internationally recognized expert on continence in older adults. He is active in national and international clinical practice guideline development and is the chair of the International Consultation on Incontinence. Dr. Wagg has significant frontline experience in healthcare administration and systems development, a strong knowledge of operational issues, and an in-depth perspective of healthcare of older adults. We will provide a web link to the article at the end of today's webinar, but in the meantime, I'd like to turn it over to Bon for his presentation.
Thank you, Kerry. It's good to be here. As you mentioned, I'll be talking to the method that we use to prepare the paper Predictors of Improvement in Urinary Incontinence in Post-Acute Care Setting. Of course, it's a Canadian cohort. I think it would be good to start talking about how this paper came about. Incontinence is one of the geriatric giants, and it has high prevalence in most settings, most certainly in post-acute care settings. And literature shows that about up to 40% of patients are affected by this condition. And why this condition is also important is that it's associated with poor quality of life among older adults, and it's certainly patients in this setting, functional decline. And one of the other things that it leads to is patients being discharged to long-term care. There are also other challenges, complications like skin breakdown, risk of fall, and some of this makes this condition a very good topic for the research that we conducted. The other thing is that the condition is potentially treatable with the possibility of improvement for some patients. Not everybody will improve, but studies have shown that some people transition from being incontinent to being continent. However, we do not yet know factors that are associated with improvement in this condition, especially in this setting. So we set about answering this question by designing a retrospective cohort analysis. And the population that we chose are a population of patients receiving treatment at post-acute complex continuing care. And I'm going to take a minute to say what complex continuing care is. These type of services are mostly specific to Ontario province in Canada and some part of Manitoba. Complex continuing care is a specialized program providing medically complex and specialized services to people with chronic care services using multidisciplinary team and specialized nursing care services. These services are usually provided in a complex continuing care facility, either located within a hospital or can be a standalone. There are links to discussions about where complex continuing care is. So we targeted populations who are aged 18 years and above, admitted to complex continuing care hospitals in Ontario, Canada, between 2010 and 2018. And to be eligible to be selected for this study, a patient must have an initial admission and a follow-up 90-day assessment. Why this is important is that a lot of people who get admitted into the complex continuing care are really discharged before 90 days. But we wanted to be able to establish people who stayed long enough to have the second assessment to show whether there was a transition from incontinence to continence. And the outcome of interest we looked at was a binary variable representing an improvement in urinary incontinence between the admission assessment and the 90-day reassessment. So we chose those who have the potential to improve. In other words, we looked at people who are not continent. That means they have room to improve. We chose those who have some form of incontinence. The independent variable we looked at that we had to include, because this is a multivariable analysis, are many. As you can see, we included things like ADL hierarchy scale, the frailty status, and some diagnoses like multiple sclerosis, Parkinson's disease, schizophrenia, and so on and so forth. For statistical analysis, we use both unadjusted logistic regression as well as multivariable logistic regression. Suffice it to say, in our cohort selection, after applying our eligibility criteria, the initial eligibility criteria of having an initial admission and a 90-day reassessment, we had 18,584 persons who met this criteria. But then we further excluded those who have complete bladder control. In other words, they do not have room to improve in their continence status. That left us with a final cohort of 13,779 patients, and this represents about 74.2% of the initial sample. And amongst these 13,779 persons, you're going to see that 36.9% of them were totally incontinent and 37.3% were somewhat incontinent. To the key findings of this study, what we found was that the strongest predictors of improvement in urinary incontinence were actually bladder retraining. And bladder retraining had strong interaction with bed mobility, as you're going to see as we go forward. Also, we found that starting a new medication 90 days prior to the initial assessment strongly predicted improvement in urinary incontinence. And the third factor that had strong association with improvement was triggering the interRAI urinary incontinence clinical assessment protocol called CAP. The first category being to facilitate improvement, and the second category being to prevent decline. So where a patient triggered either of this category in this CAP, they are more likely to improve. Then I'll speak a little bit more about interaction between bed mobility and bladder retraining. What we found was that if somebody had issues with bed mobility, ordinarily they are going to not have any improvement in urinary incontinence. But where such persons are provided bladder retraining, it exponentially increases their odds of improving in urinary incontinence, as you can see from the chart. And other things that we found in this study was that there were other factors that predicted a less likelihood of improvement in urinary incontinence. Things like being totally dependent on others for transfer. And if you are rarely or never understood by either your caregiver or the clinician or anybody around you, you are less likely to improve. And if you have a major comorbidity count of 3 or more. But significantly, we found that sex and age were not independent predictors of improvement in urinary incontinence. This is important because we know that sex and age are associated with the prevalence of urinary incontinence, but this study is showing that they are not necessarily associated with improvement. And there were other key findings that were important. Having Parkinson's disease, having Alzheimer's disease or other dementia, and having respiratory infection all predicted less likelihood of improvement in urinary incontinence. And this led us to conclude that if you have better physical function, and if you trigger the urinary cap on admission into post-acute complex continuing care, and if you started a new medication, you are more likely to improve in urinary incontinence. However, we do not know exactly why starting a new medication in the 90 days prior to admission positively predicted urine improvement. And this could be, we think this could be related to the medication directly or on the effect of the medication through the comorbid condition. So if you had a medication that made you, or like diuretics, and it was changed, your urine incontinence could improve. Or if you had medication that improved your chronic condition, this could also impact it. Finally, we found that physical function, such as ADL items, were stronger predictors of urinary incontinence improvement than were cognitive function. And there are so many reasons this could be. So we thought that possible further inquiry that this our study had thrown off is being able to ask the question of whether improvement that we found among this population predicted by UI cap triggering was actually related to caregivers and clinicians being able to use this cap trigger to institute intervention for this patient. In other words, where the improvement response to intervention that were instituted, or were they simply organic? The second question, inquiry, that we would like to see is, to what extent are people who could benefit from bladder retraining provided such intervention in post-acute care setting? We believe that this is an important study, and having this further question could further improve care planning and advantages, benefits that could accrue from the findings from this study. Thank you.
Thank you for your presentation, Bon. That was very interesting. I certainly have a lot of questions, and I'd like to start with something basic. Why is it important to understand the predictors of urinary incontinence in this particular post-acute population?
Thank you. That's a very important question. And the way I'm going to answer that question is I will approach it from three perspectives. The first one being the epidemiology of urinary incontinence. As you saw in our presentation, up to 40% of patients in these settings have been shown to have urinary incontinence. Some others, it's a range. Some other studies have shown more. And as you can see from our study, 74% of the cohort that we selected actually had some form of incontinence. 37% were totally incontinent. The other reason why this is important is that the urinary incontinence leads to complications such as risk of falls, skin breakdown, repeated urinary tract infection, general impairment in quality of life, and most importantly, people who have incontinence in this setting are more likely to be discharged to long-term care. And why is this important? The complex continuing care being a post-acute care setting with higher resources and multidisciplinary team available present a unique window of opportunity for incontinence to be addressed. And addressing this incontinence and helping those that can improve could avert people being discharged to long-term care. And there are so many benefits to that. There's a benefit in terms of saving resources, and there are some studies that have shown that high turnover of nurses could be related to incontinence. And that's why this is important that we study improvement factors that lead to improvement in urinary incontinence, especially in post-acute care setting.
Thanks, Bon. Something just maybe to go back to the basics here. Your study, I noticed, used the older MDS or minimum data set 2.0 instrument. And of course, many jurisdictions and facilities have now transitioned over to the newer interRAI tool, the LTCF, or long-term care assessment. And I'm just wondering if you could speak a little bit about how the results from your study may or may not still be applicable to the LTCF.
Thank you for that important question. I think it's important to go back to actually what the interRAI assessment instruments, especially the new instruments. So the interRAI assessment instruments are actually a rich source of information to support clinical and organization level decision making. And one of the great advantages of interRAI assessment instruments is that they share core assessment items. So whether you're using the LTCF or using the MTC 2.0 or other interRAI assessments, they share core assessment items, and they also use standardized language. So the impact of this, the effect of this is that the information you obtain from the assessment instrument remains meaningful across healthcare sectors and settings. And to bring it back to your question, the interRAI LTCF form offers similar applications to support decision making at the point of care and at the organization level. And this application are the same as those that you obtain from using the RAI MDS 2.0. Applications such as the CAP, the clinical assessment protocols, the outcome skills, the quality indicators, as well as the case mix systems are all the same. Because of that shared core assessment items and the standardized language, using LTCF to obtain information would also give us the same information that we have used MDS 2.0 to obtain. So the answer is the result will still be applicable because similar information will still be collected.
Okay, thank you for that. Now, I also understand interRAI is working on tools for many settings, including a new instrument for the post-acute care rehab setting, a rehabilitation setting. I'm wondering if you could briefly tell me a little more about that.
Yes, thank you. So what we have been doing over the past 2 years is that we have been piloting the implementation of the PAC Rehab 2, and we started that with a facility here in Ontario, Canada. And we have chosen the post-acute care setting. We've chosen a group of patients who are awaiting discharge either to long-term care or to their home. And we are piloting this tool knowing exactly that these are the kind of population that would potentially in the future need to use the PAC Rehab. As I mentioned earlier, the interRAI assessment instruments share the same core assessment items and share the same language. So the PAC Rehab also benefits from that. What we have seen so far by piloting this tool in this clinical setting in Ontario is that the care workers that use them find them very convenient to use because they have reduced number of items. They are not as large as the MDS 2.0. So what we are hearing anecdotally from the care workers is that the tool is actually meaningful. And for us, that are using the tool to obtain information, obtain insight on the patient, what we are actually saying is that we are obtaining the same information that we would want to obtain or we were able to obtain from MDS 2.0. We're able to get the CAPS, the skills, and the case mix index from this. So we are very, very excited about this tool and what it's able to provide. And we are hopeful that it's going to become a much better tool to be used across settings, especially in post-acute care setting in Canada and elsewhere going forward. Thank you.
Thanks, Bon. One of the things I really like about this series on interRAI research is that we have a panel, and so we get to bring in some other experts to comment on the research that we're looking at. And I'd like to do that now by bringing Adrian into the discussion with his expertise in the field of continence. So Adrian, I first wanted to ask you about the prevalence rate of incontinence that we saw in the study that Bon presented. And this particular cohort, it seemed very high to me at 74%. Did that surprise you?
In fact, it didn't. I think, as Bon suggested, previous data gave a range of up to 40%, but largely these are older data in different populations with different questions. And I think here we have a systematic assessment in an enriched, complex continuing care population of multi-morbid, medically complex older adults. So this would entirely be in the range of those estimates that come from long-term care, in fact, and this would be the destination of quite a considerable fraction of this population.
So obviously you've done a ton of research in this area, and I'm wondering if you can comment on the implications for the care team working in post-acute settings related to the association of bladder retraining on urinary incontinent improvement. How does that fit with previous research you've done, maybe in different settings like in residential settings?
I think the use of the assessment index and the caps here are a great step forward in the systematic assessment of people with incontinence, which we know is often poorly done, where staff have limited knowledge. Now, the fact that we've identified that bladder retraining per se as a behavioural intervention may be of particular value, I think it is highly relevant. We show that the improvement can be associated with improvements in mobility, and clearly there's a parallel process going on with rehabilitation here. But the bladder retraining as defined as a sequential delaying of avoiding in response to urge addresses the probably the primary cause, underlying cause of incontinence in this older adult population, but also starts to address some of the underlying physical impairments that might be associated with disability-associated incontinence. So I think, again, demonstrating the power of the cap and the precipitant of action.
Thanks. And for those of you watching who are wondering what a cap is, we're going to come back to that in just a minute. But first, I wanted to pick up on something you said, Adrian. In the study, the effect of cognition on urinary incontinence improvement was not as pronounced as that of poor physical functioning. And I'm wondering how might this contribute to our understanding of continence promotion in persons living with dementia?
Again, I think the finding is extremely liberating. You often find that people living with dementia are excluded from studies of treatment of urinary incontinence by virtue of having a dementia diagnosis. That would be unfair. And in fact, yes, the prevalence of a diagnosis of incontinence in dementia is higher, but that doesn't exclude people from the potential of benefit. Undoubtedly, in the studies we have in post-acute and long-term care environments, the maintenance of mobility and physical function is far more important than anything else. And providing that people maintain their mobility and have the ability to change behaviors with cognitive impairment, then they will improve. So I think this is a really powerful reinforcing statement that because you have some degree of cognitive impairment, this should not exclude you from active treatment of your incontinence.
Okay, thanks for that, Adrian. I'd like to bring our last panelist, Melissa, into this discussion, who of course brings with her a wealth of expertise in a variety of areas. And I do want to go back to that issue of the caps, for people who are just starting out on their journey with interRAI or MDS tools. That's a term you're going to hear a lot. And certainly the study told us that one of the strongest predictors of positive improvement in urinary incontinence was the triggering of the cap to facilitate that improvement or prevent decline. So why don't we start? What is a cap? Can you tell me a little bit more about that?
Sure. Thank you, Keir. The CAP, or the clinical assessment protocols, are a unique automated feature of interRAI systems. So when an interRAI assessment is done, it's done within a software system. And at the end of the assessment, the caps are automatically generated. And then it becomes a flag for the clinician of areas where the person may be at risk of decline or has the potential for improvement. And I think it bears saying again, I know Bon shared this in his presentation, that in our study, people who triggered to facilitate improvement on the urinary incontinence cap were 1.3 times more likely to improve incontinence. And those that triggered to prevent decline on the cap were 1.32 times more likely to improve incontinence. So it was a real strong indicator and flag for the clinical team, or it would be, to support persons in improvements in continence. The incontinence cap is just one of many caps that are developed using interRAI data. Other caps that can be generated from the MDS instrument, or as Bon mentioned, the long-term care facility, or the new post-acute care instrument would be things like bowel conditions, physical restraints, mood, cognitive loss, physical activity promotion, and many others. So the urinary incontinence cap is automatically calculated based on an algorithm that sits inside the software. So clinicians don't have to do any calculations. And it's derived from a set of variables looking at the level of incontinence, a person's cognitive abilities, their dependence for mobility, or any some indicators that might indicate the person's status is fluctuating, like maybe they had a recent fracture or infection. And all of the caps are based on systematic reviews of international literature and the large data holdings of interRAI. I guess I should just add, though, even though it is automated and built into the software system, the caps aren't intended to automate care planning. They're designed to be used by the team to engage the person in a dialogue, really, about their health and their goals for their stay, to support collaborative decision making. So in this study, we did see that the cap was helpful to identify people who have the potential to improve incontinence. And if that was then a goal of that person, a care plan could be developed with the person and the team.
Okay, so that makes a lot of sense to me. I don't have a clinical background myself, but certainly having worked with many nurses and other clinicians who've used the interRAI tools, there is that little bit of that learning curve where you're maybe moving from a much more unstructured, qualitative clinical assessment to something that's a little more structured and incorporates research in real time into what you're doing and really helps facilitate the dialogue with the broader care team to support that collaborative practice. So that seems like a lot of win-win-wins to me. And I wonder if we could just bring it down back to the issue of urinary incontinence and the cap associated. And specifically with that example, how would it assist a clinical team in the post-acute setting?
Yeah, well, I think it's just as you said, it provides some structure, a reminder, a helpful flag. So if we're thinking of post-acute settings like the complex care hospitals in Canada, we often have interprofessional teams working together to support patients. So reviewing the cap or the caps that have been triggered for an individual at a team meeting is a really helpful way to plan and organize care. People that are admitted to these types of post-acute care settings are not able to return home after a hospitalization because of the complexity of all of their care needs. So they're likely to have a number of concerns that will need to be addressed by the team in order for them to return home. So I think that's where the caps are helpful, that you can review them as a team with the patient and prioritize what might need to be addressed first. I'm thinking, like, for example, pain before we might start working on improving continence or mobility. When I practice as a registered nurse in home care, I really counted on the caps along with the clinical scales as a helpful starting point for me to know what areas my client is going to need further assessment.
So picking up on that a little bit, and just thinking a little more broadly, how can nurses and that interprofessional team use information from the MDS or interRAI tools and research studies like the one we've just talked about for more of that program planning, kind of quality improvement work, the things that happen at the unit or the hospital or the regional level for those post-acute settings?
That's a really great question, and I think this is the real perk of interRAI assessments for the interprofessional team and the healthcare managers and leaders that support them. Because again, the information from the interRAI assessments are collected with a software system, the outputs can be used at the point of care, like we were talking about with the CAP, to create a care plan with the patient. But that same information can also be used at the organizational level. As reports can be generated on an assessment item, like incontinence, or on different clinical scales, risk stratification tools that are available in interRAI instruments and the CAPs as well, but across all patients in that setting. So what this really kind of comes down to is that the team only has to collect information once, and then they can use it in multiple ways. So rather than collecting information from the patient and then using other means to collect information about how all the patients are doing, they can leverage the the reporting features in the software. So a complex care hospital could use their individual patient assessments during team rounds to care plan and evaluate that person's progress. But they could also have a snapshot of the prevalence rates, for example, of incontinence on their unit, and quality indicators for the whole patient population, such as looking at worsening bladder continence. And these quality indicators are risk adjusted and then can be really helpful to monitor quality over time. And the team, the managers, leaders, they could review these indicators at designated intervals, like quarterly or less frequently.
So it sounds like it's becomes more of a primary source of information rather than relying on secondary, kind of less reliable sources of information to monitor performance and quality and safety, which is good. Here in Manitoba, we all love twofers, which is shorthand for 2-for-1 deals. And so it sounds like you've just laid that out. There's a big benefit on the front line at the clinical level, but there's a benefit at the same time without any extra data collection at that unit or facility level to do the broader work to improve care. And sometimes what makes this real for people is an example. So I wonder if you might have an example you could share, Melissa.
Sure, I love that. A twofer, that's what this is. So I was thinking maybe like a clinical nurse specialist from a complex care hospital, maybe in Manitoba. They might read our study and wonder, like, what is the prevalence of urinary incontinence, and how are we managing it in my setting? And are we providing bladder training for patients? What does that look like? And what does our team do when the urinary incontinence cap triggers? And she could be thinking about kind of the buzz she's heard on the unit in rounds that people's continence matters, and it's a critical factor in returning patients home. So then she could think about or determine how the program supports patients in regaining their continence during their admission using their own interRAI data. So there'd be no need for her to survey all the inpatients at one point in time regarding their continence status, for example. They have the data and the software that would allow them to do that. So then I could envision she could bring that information to the nursing practice council or whatever related governance structure at the hospital, and begin the process of examining their nursing and team practices and monitoring their progress over time. Because you can't improve what you don't measure, right, in healthcare. So having that quality indicator built into the patient assessment system is a really efficient way to move towards being more of a learning health system, where we're conscientiously striving to achieve the best possible health outcomes or care.
That's great. Well, I want to thank all of you for your time today, Bon, Adrian, and Melissa, and for your work on this very interesting topic. Certainly, I think most of us, if not all of us, look forward to some future developments in this important research and applications to all of our different work settings. I'd like to thank you for watching our presentation today on interRAI's innovations in the application of interRAI assessments. If you would like more information about this or other related work, please contact us at info@interRAI.org. That's info@interRAI.org.
If you would like to learn more about the research presented in this video, please use this QR code to access the scientific article.